Thank you. You make me sound so much better than what I really am. First of all, I would like to thank the organisers for their very warm invitation in inviting me to speak, and they gave me my title, Separating Trishna and Krishna. But personally, I prefer this title, which is an alternative title provided by my anaesthetic colleagues, because I believe it more accurately highlights the role of the team in what I can now say, in retrospect, was really a formidable undertaking by all. So to put the problem into perspective, craniopagus, or conjoining of two individuals at the cranium, was first described in the 1770s by Sir Everard Home when he described a case of craniopagus parasiticus in twin boys in Bengal. Historically, throughout the ages, in both children and adults, it's been reported both in the media and in medical literature, but primarily as objects of curiosity. It's in fact exceptionally rare, with 0.6 cases per million live births in children in the US. The twins are identical, they're more common in females, and of the craniopagus pregnancies, 40% are stillborn, 33% will die in the perinatal period of organ failure, and in reality, that's a survival incidence of 1 child per 10 million live births. When you look at the literature, 22 cases have been reported until 1987. Without surgery, 90% of their live children will die before the age of 10. Of those that have surgery across the board, over 1/3 will die from the surgery. And the first survival from surgery was reported in 1953, and this was the Brody twins in the United States. However, one child was deliberately sacrificed to save the life of the other. Since then, there have been reports of successful survival, although almost all of these have a degree of neurological impairment. The classification of craniopagus twins was actually best defined by Stone and Goodrich in 2008, and it falls broadly into two groups. There's the partial craniopagus group, where surgery has a mortality around 14%, but nearly 3/4 of the survivors are normal or near normal in cognitive functioning. The worst group is the total craniopagus, and that's where our twins fall into. And these children have a mortality much closer to 50%, and only about 1/4 will have normal or near normal cognitive outcome. And they went further to devise a grading system based on the degree of communication of the neural tissue, vascular tissues, and soft tissues. And they gave a score between 10 and 28. So where do Trishna and Krishna fall in this? These were two twin girls found in an orphanage by an aid worker in Bangladesh, which we all know, and they were brought to Australia by the Children's First Foundation. They were accepted by the Children's Hospital for an assessment only. No one knew whether we could help them or not, and we did not even know if surgery was feasible. We knew nothing about them. This was the only image we had when we agreed to accept them for assessment, and it appears that they're thriving. The reality, in fact, was vastly different. They were 9 months old. Twin 2, in fact, had severe biventricular failure, was in severe pulmonary hypertension with a dilated heart. The shared circulation was clearly life-threatening to both children. And in fact, from the outpatient clinical first hello review, these children were admitted to intensive care, and one of them underwent an urgent tracheostomy. So what I would like to highlight in this talk are some of the challenges and the lessons that we faced in managing these children. In particular, I'd like to outline some of the ethical questions that were posed. The challenge of attempting to manage a condition that you've never seen before, performing a procedure you've never done before, and one with high morbidity and mortality, and how you go about amassing the team to do this and managing the team that is required. So the first hurdle to tackle was in fact the ethical dilemma posed. we had just admitted 2 non-Australians with a complex medical and social problem and intubated one of them. So specifically with respect to the girls, the questions that we raised were, do we have a right to intervene given the significant morbidity of surgery? We've got 1 child intubated, but do we just stop there? Given that 1 child was very sick and 1 was much better, do we have the right to save 1 child over the other? Could we sacrifice a child? Or could we allow 1 child to die because of the other? And if we do embark on treatment, will that have an impact on the formative years of these children as toddlers without parents? There were questions for the broader community. Who will pay? These are non-Australians. Will this disadvantage Victorian children because the resources required to manage these children are enormous, and at the time we reviewed the children was totally underestimated by, I think, many in our institution. Sorry, go back. Would the money be better spent in programs to help children overseas? The money we would spend on 2 children would perhaps aid many more children in Bangladesh. And above all, we had a role to protect the privacy of the twins, given the curiosity around such a rare medical condition. And the majority of images that you will see in my presentation have already been shown in the media. And lastly, we had a role to protect the twins from exploitation. So what lessons did we learn? First of all, the role of the ethicist in this process was absolutely crucial. As clinicians, we make a myriad of daily management decisions based on a simple premise to first do no harm. In the context of 1 individual, that process may be very straightforward, but where you have competing interests or more than 1 individual is involved, it can be quite difficult to make an unbiased judgment, and the wisdom and the impartiality of ethicists, what they provide, is essential. As a consequence of that process, we decided that whilst resources could have been spent differently and perhaps more effectively, we had to decide in favour of the child that was before us. And we decided crucially that both girls had an equal right to our best efforts and the chance of a normal life. So having bridged the first hurdle, the second aspect was, how do we set about managing a condition that we've never managed or dealt with before, and perform a surgery on a magnitude that far outweighed any of our previous experience? When confronted, we do what everyone does. We read the literature and we consulted widely with our colleagues. And it's very important to remember we do not need to reinvent the wheel. Now, I was very fortunate at that time. 2 of my colleagues, one was Jack Walker and Jim Goodrich. They were both co-workers in a teaching course that we run in Southeast Asia, and both had been involved in separating conjoined twins. And the review paper that was published a year after we first met the twins was actually in press at the time, and so I was very fortunate to have Jim's advice on this case. He subsequently published his data, and he devised a definition of 24, a level of 24 on his scoring system, which implied that there were significant connections between the 2 twins, and that separation with a level over 24 was not possible. So where do our girls fit in? They had a score of 21, so it's daunting, but doable. When we analysed the girls, the brains were mostly independent, which was fortunate. However, there still were interdigitations. These, fortunately, were not in areas of significant function. They had an independent arterial system. They did, however, share a single dural sac, a single skull, and a shared venous circulation. When you looked at the literature, and this is from Jack and Jim's work, single-stage surgeries, which had previously been reported, had a very high mortality in this group. And they proposed a strategy where we slowly separate the venous connections of twin 2 from twin 1 and allow twin 1 to slowly form venous collaterals. Sorry, twin 2 to form venous collaterals. So we thought out a steady staged approach. We aimed to achieve independence of the brain and the blood vessels prior to the last separation. We aimed to have complete recovery between the stages. We wanted our children to thrive throughout the process. And we maintained an open-ended program, so whilst we had a series of steps in mind, we were prepared to change that at any stage based on the condition of the children. What did this mean in reality? This is what we underdid. It was an embolisation at the Royal Melbourne, a series of venous and brain separations. Some of those, in fact, also lasted over 20 hours and were not reported in the media. And then a final separation that was very well publicised in 2009. The first step, in fact, was performed quite urgently, prior to any extensive planning, due to the need to reduce the shunting between the children because it was life-threatening. And the problem in reality is physiologically quite interesting. We have a very innovative radiology and MRI department at the Children's Hospital, and at the time a new sequence had just come out on MRI called a twist. We had not tried that at the Children's before, we now use it not infrequently, and it enables us to use the MRI to adapt to give an angiogram-like approach. So as you can see, you have blood flowing very rapidly from twin 1 to twin 2 across a very broad venous sinus. Twin 2, however, has much less crossover back to twin 1. So the blood is shunting from twin 1 to twin 2. And in fact, this is very similar to what Jim Goodrich experienced in the Montefiore twins. So we have the two twins, the Montefiore twins. They have a significant crossover. This leads to increased venous return, increased right atrial pressures, increased cardiac output, increased blood pressure. One child is chronically slightly overfilled. The other child has the exact opposite, decreased venous return, and this child is chronically slightly underfilled. But they seem to manage into some form of equilibrium. And the only way to improve it was to separate them. Our twins were very similar, in fact. They had a similar crossover with a very large dumping of blood from twin 1 to twin 2. This caused a significant increase in venous return and right atrial pressures, an increased cardiac output, but because of the minimal flow in the reverse direction, this caused pulmonary hypertension and failure in twin 2. Twin 1 therefore had a reduced blood volume with decreased venous return and had a moderate degree of hypotension and was chronically slightly underfilled. So the situation we were presented with is this scenario, as you can see in the top. Doesn't focus so well. And what we ideally wanted was the situation down the bottom. So the solution to try and achieve this in these two very ill children, in fact, was to innovate and to adapt techniques we had tried before. Personally, I did not feel that the twins would cope with a surgical obliteration of the venous connection, given the degree of cardiac failure in twin 2. I was concerned that there would be significant venous pressure changes between the two twins and the cerebral blood flow, and I was concerned about brain swelling, and my inability to manage that if the head was open. So I approached my colleague, Peter Mitchell, who's an interventional radiologist at the Royal Melbourne Hospital, and asked him to do something that he also has not done before, and that was to treat this endovascularly. Now, I have to say, both of us were outside our comfort zones, and neither of us really knew quite what to expect. And I think it's important when we're dealing with a team, and as what I ultimately evolved to become team leader, was that in this scenario, it's very important not to abandon your colleagues. So whilst I physically had nothing to do in the embolisation process, I am tucked in there in the background, so that should a disaster occur, that burden would be shared between us. So the embolisation was occurring. Peter very nicely coiled the connection. And as you can see diagrammatically, this is the end, this is a twist sequence showing obliteration of the communication. And diagrammatically, we managed to stop the shunt from twin 1 to twin 2. Physiologically, a very interesting thing now happened. Twin 2 was no longer getting the huge blood volume from twin 1, so her venous return reduced, her cardiac output reduced, and she became quite hypotensive because her heart was dilated and she was in cardiac failure, she wasn't able to compensate, and she became significantly hypotensive post-embolisation. On the contrary, twin 1 had an increased venous return now, increased cardiac output, and became quite hypertensive. And suddenly, on post-embolisation, still at the Royal Melbourne, we had this huge disparity. You can't give drugs to treat one because there's still a cross-circulation and it will treat the other, and they're acting at cross purposes. And in fact, a simple but bright innovation was discovered by our anaesthetists, and that was simply to change position and to gravity feed twin 1's blood into twin 2. And this actually led to quite some innovative nursing by our nursing staff to manage our children for almost the entire 2-year period with one child elevated above the other. So having now stabilised the twins, we can now concentrate on the task at hand, and that is a series of divisions of the venous connections and the brain tissue. And it's at this point that we amassed the team. What was actually critical to realise was the equal and essential role of all the team members, be they medical, surgical, anaesthetic, intensive care, allied health, nursing, staff technicians, and administrative, and the ethicists. We established regular meetings, particularly pre-procedural, and mapped out the goals of each intervention, the potential complications, each scenario that may arise, and our management strategies for these. We tackled every problem both in isolation and with respect to the broader management of the children. And all potential solutions and strategies were countenanced. We had plans A, B, C, D, and E for as many complications and outcomes you could imagine. And what was also important at the time was to understand across all team members the individual needs of each member and the goals that they were trying to address and how that fitted into the bigger picture. So, for example, post-embolisation, twin 1 remained chronically hypertensive, developed left ventricular hypertrophy and required antihypertensives and had a high urine output. Twin 2 resolved the cardiac failure but now was chronically hypovolemic and remained anuric up to separation date and was effectively dialysed by twin 1. And this posed quite a number of repeated challenges for both our anaesthetic department and our intensive care team. And the challenges they faced were twofold, really. One relates to the shared circulation and the difficulty this had in terms of anaesthetising these children, providing airways and intubation for them and venous access. And the second related to equipment, transport and planning for their multiple procedures and investigations. So the shared circulation meant that these children had a simultaneous anaesthesia. When you started anaesthetising one, you're anaesthetising the other, and the blood pressure management proposed a significant challenge. Intubation, in fact, was quite tricky and required very good communication between the two teams. So you can see the team on the right of your screen working on twin 2. That's a bit easier because she's already got a tracheostomy. The team for twin 1 are trying to intubate her, but team for twin 2 are getting in the way and they have to move and adjust and coordinate the intubation. For the management of the blood pressure, clearly what we gave to one affected the other, and ultimately manage them with both PEEP and posture. And as I said, the nursing staff, both on the ward and intensive care, developed quite unique ways to manage these children. What we also learnt was that ultimately not all our ideals could be achieved. And as a team, we had to accept this because cure at the end of the day was only through separation. And so we had to modify our goals. Vascular access was particularly pertinent. There was one overriding proviso to these girls. never in the neck because they needed collateral circulation. And all venous access or arterial access was precious because these girls were undergoing multiple procedures. So in fact, all of them had ultrasound guidance. And every line was challenged. Transport alone was challenging. For example, the trip to the Royal Melbourne Hospital, not everything could fit into the ambulance. It just physically wasn't possible. In reality, the multiple trips to the MRI and the theatre, in fact, were managed quite well, but they did take a lot of planning and it needed certain amounts of equipment and the teams. And we soon became used to a regular team involved in the care of these children. So here you can see we have 2 of everything ready for the children, except for the bed, and involves 2 anaesthetic teams. Even the logistics of transporting the children to the MRI scanner, for example, were much more complex because of their physiology. And it became important that all the teams involved in their care and their transport had excellent communication to understand the physiological needs of these children. And this is particularly so both in the surgical and medical teams, but also through intensive care, where the teams tended to rotate on a frequent basis. On the reconstructive side, the challenge faced by our plastic surgeons was formidable, and probably one of the most complex composite reconstructive challenges they would ever face. To reconstruct the dura, we used synthetic dura. They initially tried to use fascia lata expanders, but failed and was not possible. The large cranial defect was reconstructed using Med-Por because there was insufficient bone tissue. And the skin and scalp was through tissue expansion. But at the end of the day, reconstruction must work well for them first time because failure was not compatible with survival. We then engaged modelling companies who offered to create a 3D model, which in fact was incredibly useful and enabled us to visualise the various layers involved and the anatomy involved, because it's quite complex anatomy to get your head around. And we would take these models to the operating theatre frequently and reassess where we were at every stage. Even the skin incision required a lot of detailed planning. It had to be planned prior to any of the procedures because it had to allow for separation of the brain and the bone. It had to allow for the expanders to be inserted, and ideally we tried to have a hair-bearing scalp. Then as a team, prior to any surgery, we would go down to the operating theatre. One of our members of nursing staff devised a conjoined twin model. So she got 2 plastic dolls and had them stuck together. And whilst it sounded quite cute at the time, it actually was incredibly useful because trying to even work out how to position the operating table became quite a challenge. As you can see here, trying to work out whether there's 1 table, 2 tables, and how they would be positioned. The plastic surgeons were there for every surgery, planning out the skin incisions, and then surgery would proceed. And that would involve both dissection of the veins and would also involve separating of cortical tissue and implanting synthetic dura to start providing a permanent sac replacement for the girls. Tissue expanders were then the penultimate stage. So we inserted 7 expanders through a keyhole approach, again to minimise blood loss, but also to minimise devascularising the scalp flap and to minimise loss of vascular channels. And then we hit our first setback and our major setback. 8 weeks into tissue expansion, the children developed an infection secondary to other reasons, but this contaminated the expanders and they had to be removed. And this was a major setback because for 6 months we could not do anything. We had concerns that the children were becoming older and larger and now would no longer fit in our MRI scan, and the potential to open up already closed venous channels. Morale across the team became pretty low at this point. And it was important as team leader to keep reminding the team about the larger objective ahead and not to become focused what in reality was ultimately going to become just a hiccup. Reinsertion of the expander was possible 6 months later and proceeded without complications. And then we come to the big day that everybody knows about. And whilst all the media attention was focused on these 2 days, in reality, apart from being a test of endurance, all the challenges we faced on those days had already been met and overcome. So we had a plan. The children were admitted the day before. They were intubated, had lines put in, angiogram was done, and they were in ICU overnight. So that on Monday we could get an early start. I had a theory in my mind we would finish by midnight. And we arranged appropriate surgical, anaesthetic and nursing teams to cope with that contingency. On the day, all the regular teams were there. We had plastic surgeons, neurosurgeons, anaesthetists, theatre staff. This is our theatre setup. We used the largest theatre we had available in our hospital. Unfortunately, it didn't have a pneumatic drill. That was one of the small things we had to overcome. It did have a viewing gallery, which was unfortunate because it did mean that lots of interested parties and bystanders wanted to drop in. But it was the largest area we had available. Plastic surgeons started. The tissue expanders were removed and then they were sutured back into place to maintain expansion of the skin. It actually became quite tricky for the neurosurgeons because we had to work around these, and then the neurosurgeons became involved. The hurdles we faced in that operative time was maintaining the tissue expansion because if we lost a lot of skin, we wouldn't be able to cover the cranium afterwards. Our goalpost shifted during the case. I thought prior that all the venous connections had been removed. I also thought that the area of contact left between the 2 brains was very small. In fact, I was quite wrong on both accounts. And midway through the case, we realised there was still a significant venous channel. And the problem for me is that I had no idea at that stage knowing what that might do to take the last dividing connector between the 2 girls. This was reported in the media. The work was so painstakingly slow that we progressed at 10 millimetres an hour, and I'm sure that was true. It certainly seemed like it. And that has implications for your physical endurance. We had one break about 5 o'clock in the morning when I think I had a shower, Alison had a long breakfast. Our muscles were sore and tired. It was also psychological hurdles. When having one of the biggest negative moments was we had cycling of theatre nursing staff. They are on 8-hour rotations, and to come back 24 hours after the start and see the same set of nursing staff I saw at the beginning was really quite a difficult moment. And we almost questioned that we should stop at that point. Having said that, we couldn't go back, and we then hit the eureka moment and finally turned to Alison and I said, I think we've done it. Following that, however, there was now another 6 more hours of reconstruction. And ultimately, separation, I'd like to think, was by the surgical team. In fact, it's by the anaesthetist manning the operating table controls and cutting the final drape. And we're now in 2 teams. And you can see there's quite a large number of people here. I'll speed up in the interest of time. And our anaesthetist is finally happy because our 2 girls have now normalised their blood pressures for the first time in 2 years, and twin 2 finally makes urine. So what are my reflections on the planning and the logistics of the team? We were constantly uncertain of the outcomes. We were constantly breaking new ground for all of us, and collectively we became very good at problem solving. There was always a core group involved, and I apologise to my intensive care colleagues because they were unable to be here for this photo, but their work in this was in fact critical. But in fact, we represented a much larger team of people, and there were many, many more contributors to the positive outcome of these children. There was also key ward and nursing staff involved in the care who found new and innovative ways to manage the girls. And the second reflection I'd like to have is on how we go about managing such large numbers of people over 2 years, and on our day and on the day, and our ability to manage the media. We started off on the day with a small team. We ended up with a massive team, and this is quite daunting for a surgeon in terms of infection, noise control, keeping onlookers out. We had to throw out people who weren't essential. And media in particular was quite difficult, and we in fact were very fortunate this was well managed by our institution. They developed an executive plan to reduce the pressure on our team. We had a documentary team create a video that acted as a buffer so nothing went out to the media until the very last moment. We held a press conference 3 days prior to the last operation, and we had a spokesperson. And what that meant was it allowed the rest of us to get on and do what we needed to do without thinking about what was happening outside. So in conclusion, the lessons that we have learned. Communication among the team is absolutely vital. We need to understand what each team member needs and what the constraints are that they're working under to make progress. We should not be afraid to innovate. In fact, most of the most useful suggestions came from the bizarrest quarters of the biggest team. I think it's very important to be aware of human factors, particularly those that lead to negativity and that will limit a positive outcome. And as a team leader, I think one of the roles is to provide support to your team, both in periods of low morale, frustration, and particularly when you're asking your team members to step outside their comfort zone. It's very important that they don't feel to be doing that on their own. You need to constantly reappraise your pathway to get to the goal that you need and be prepared to be fluid in your management. And that planning is absolutely critical and was essential for every step of these girls' case. There was nothing in reality that was not predicted. And the ultimate lesson that we learnt, that when confronted with a seemingly impossible task, a well-formed team has the expertise, the intellectual prowess, the management systems, and the ability to function to achieve success. Thank you.